Hello and welcome everyone to our next video on hemodynamic monitoring, that is pulmonary circulation. Pulmonary circulation is the other part of circulation which we do not measure much. This starts with the right ventricle, and by the blood which goes through the lungs, it reaches the left atrium. It also has intrapulmonary shunts like the pericapillary arterial anastomosis and the deep true bronchial veins. And apart from that, it also receives some circulation from the systemic part, that is the bronchial circulation. However, we will mostly focusing on the pulmonary artery and how the blood reaches the left atrium. Now, the structural characteristics of the pulmonary veins. There is a functional difference between the systemic and the pulmonary circulation. The pulmonary circulation differs in its shape, structure, and compliance from the systemic circulation. The media of the arteries are much thinner compared to the systemic arteries. The difference in the blood pressure between the two is related to the high resistance arterioles in the systemic circulation that are missing in the pulmonary circulation. In the absence of these, much of the pressure in the pulmonary artery is transmitted in a highly pulsatile flow to the permeable pericapillary arteries and the alveolar capillaries and to the pulmonary veins. So there is a significant pressure difference which is quite obvious. The effect of inflation on alveolar and extraalveolar vessels can be seen over here. Extraalveolar vessels, that is both the arteries and the veins, are surrounded by a sheath of loose connective tissue connecting the origin of the pulmonary lymphatics. The alveolar septa insert radially to the sheath of the loose connective tissue, and the results in subsequent radial pull, which is exercised by the alveolar wall during inspiration and expiration, resulting in creation of a perivascular subatmospheric pressure, leading to increase in the extraalveolar vessel diameter. However, there are some corner vessels which are located inside the alveolar parenchyma and therefore not surrounded by the connective tissue. They are protected from high alveolar air pressures and are therefore open in both inflation and deflation. These vessels are characteristically found in the west zone 1 and 2 of the lungs. Now, the transpulmonary driving pressure is a very small gradient, but it has extreme importance. So the driving pressure is the pressure in the right ventricle and the left atrium, while the pulmonary artery pressure is 30/10, which comes to an average of 15. So the gradient between 15 and the 8 pressure in the left atrium gives us the transpulmonary driving pressure. Now, the limits of normal pulmonary blood flow, that is the normal values, can be seen over here. The cardiac output, which is equal to the cardiac output that is coming from the left ventricle. The systolic pulmonary artery pressure, which is average 20, ranging from 13 to 26. Diastolic ranges from 6 to 16, while the mean ranges from 7 to 19. The capillary pressures, which are slightly lower than the mean pressure, they range from 18 to 12. The occlusion pressure, that is the left atrial pressure, is slightly lower than the capillary pressure and range from 5 to 13. And the vascular resistance is around 50. Now, the measurement of the pulmonary vascular resistance is done by 80 multiplied by the mean pulmonary arterial pressure minus of the pulmonary aortic occlusion pressure, whole divided by the cardiac output. Pulmonary arterial occlusion pressure is the surrogate which is used for left atrial pressure. Now let's see what are closing pressures. If we chart the cardiac output with the mean pulmonary arterial pressure, we get a graph like this. This graph is displaced up in disease conditions. However, it reaches the baseline over here. This is with a constant left atrial pressure of 6. However, when we chart the left atrial pressures with the mean pulmonary artery pressure, in normal the graph remains the same. However, with a constant cardiac output, as the left atrial pressures go down, at one point there is no more change in the mean pulmonary artery pressure. The graph becomes flat despite of decreasing left atrial pressure. This is the pressure where the vessels are closing and the left atrial pressure is no more getting transmitted to the pulmonary artery. So even if you are doing an occlusion, the left atrial pressures are not transmitted because the closing pressures are reached. This can happen in disease conditions like ARDS. There are two ways by which we can measure the capillary pressure. To measure the capillary pressure, one method is to measure the pressure at T0, that is the time of occlusion, plus 150 milliseconds, which will give us a measurement of the capillary pressure, which is this point. So if we look at the pressure, this will come to here. The other method is there are two phases of this decline. Once there is a occlusion, there is a first rapid phase, which is because of the resistance, and then a capillary phase, which is the slow phase. So visually, if we want to calculate, we have to find the inflection point. From there, we draw a line back to the T0. There, the intercept will give us the capillary pressure for the pulmonary bed. Now, how to measure the transpulmonary pressure gradient? The transpulmonary pressure gradient is mean pulmonary pressure minus the left atrial pressure. However, the surrogate that we use is the pulmonary artery occlusion pressure. Now, it is an assumption that pulmonary artery occlusion pressure is equal to left atrial pressure and is equal to the effective closing pressure at zero low states. Now, the transpulmonary pressure gradient had previously been incorporated into the pulmonary hypertension guidelines, and a cutoff of more than 12 was used to help differentiate isolated post-capillary from mixed pulmonary hypertension. However, there are a lot of limitations in this kind of a measurement. This value can be affected by the stroke volume of the right heart, by the compliance, and the change in the blood vessel characteristics. So, the guidelines have recently suggested to integrate the use of diastolic pulmonary gradient. The diastolic pulmonary gradient is calculated by subtracting the pulmonary artery occlusion pressure from the diastolic pulmonary artery pressure rather than the mean pulmonary artery pressure, since the mean pulmonary artery pressure can be affected by various other factors. A normal diastolic pulmonary gradient is around 1 to 3, owing to the large capillary reserves which offer low resistance to the running off during diastole. So a value of more than 7 is suggested as discriminating between pulmonary pressures elevated due to passive upstream transmission of the left atrial pressure, that is isolated post-capillary pulmonary hypertension, or from increased pulmonary vascular resistance due to pulmonary vasoconstriction or pulmonary vascular remodeling, that is a mixed pre and post-capillary pulmonary hypertension. So these values can be measured through the pulmonary artery catheter. Apart from that, we can also use the echo, that is the tricuspid valve maximum velocity, the mitral valve EE prime. So based on that, if there is a normal pulmonary artery pressure and elevated left atrial pressure, then it is associated with left heart failure. And if the pulmonary artery pressure is also affected because of it, it is called the post-capillary pulmonary hypertension. If all the values are low, it is considered normal. However, if there is a normal left atrial pressure and elevated pulmonary artery pressure, it is the precapillary hypertension. Now there is also a role of the pulmonary arterial compliance. So there is a vein which is the reservoir. There is a power generated by the contraction of the left ventricle. Then we have the compliance of the arteries. So finally, which runs off into the left atrium. So this is the contraction of the left ventricle. While the pulmonary artery, there is a runoff. This runoff gives us the RC time. We'll come into the details. The arterial time constant of the pulmonary circulation, that is RC, is thought to be a constant in health or disease. So this RC is considered to be a constant. It is equal to the pulmonary vascular resistance multiplied by the compliance. Next, what we come to know is the pulmonary vasoconstriction due to hypoxia. So when there is a hypoxic alveolus which is not taking part in the gas exchange, what happens is the pulmonary circulation causes a constriction of the vessels which are feeding those alveolus. So the more blood is transmitted to those alveoli which are having good oxygen supply. So finally you get more oxygenated blood going out. So this is a defense mechanism of the body to maintain oxygenation even when some alveoli are affected. Now the hypoxic pulmonary vasoconstriction is a quasi-intermediate and evolves in two phases. An initial constrictor response that starts within minutes of the hypoxia, and a second sustained phase that results in a plateau which is approximately within 2 hours. Now this is mainly because of factors that are affecting the oxygen balance, that is the redox balance. In an oxidized state, these parameters are maintained, resulting in the closure of the calcium channel and opening of the potassium channel. However, when it is reversed, that is the redox balance is reversed due to low oxygen levels, the calcium channel opens and the potassium channel closes, resulting in vasoconstriction. Now coming to the most important aspect that we need to deal in the ICU, that is pulmonary hypertension. For all practical purposes, we diagnose pulmonary hypertension when the mean pulmonary pressure goes above 25. However, there are various classifications. The WHO classification is into 5 groups. The precapillary is when the mean pulmonary artery pressure is more than 25, but it is associated with a low occlusion pressure, which means the other side is not affected. This can happen in pulmonary artery hypertension class 1 due to lung diseases, due to chronic thromboembolism, or due to unclear multifactorial factors. Post-capillary is when both are elevated, that is the mean pressure as well as the occlusion pressure, which signals a defect in the left heart. So when you find a post-capillary, you have to next look at the diastolic pressure gradient and the peripheral vascular resistance. If both are decreased, then it is a isolated post-capillary. That is, the gradient is not elevated and the resistance is also normal. However, if they are elevated, it means there is a combined post and precapillary pulmonary hypertension. Now, how to diagnose pulmonary hypertension, especially at the bedside? Using of pulmonary artery catheters is very difficult and cumbersome, and recent studies have shown that it is of not much value. Even the interpretation is very difficult. So what we try to do is do echo. So this shows a pulse wave Doppler, this wave. This is showing a pulse wave Doppler of the right ventricular outflow tract and measures the pulmonary valve acceleration time, the PAT. From this, we can try to measure the pulmonary hypertension. Apart from that, this shows the pulse wave signal in the RVOT, showing the notching of the RVOT. This signifies a significantly elevated pulmonary vascular resistance. Now coming to this is a continuous wave Doppler, which is done on the tricuspid regurgitation jet. That is, the maximum velocity is calculated, the TR max value, and the pressure gradient is calculated using the modified Bernoulli's equation. In that, you add the right atrial pressure, and it gives you the pulmonary artery systolic pressure. And this is the continuous wave Doppler of the right pulmonary regurgitant jet and measurement of the end diastolic velocity and the pressure gradient, which again is calculated from the Bernoulli's equation, and adding the right atrial pressure, it gives us the pulmonary artery diastolic pressure. So this is how we can use echo to diagnose pulmonary hypertension. But however, this is not something which has been clearly established. We need more studies, more correlations to actually use them at the bedside, especially in critically ill patients in whom getting such clear views and clear measurements is very, very difficult. The other thing that is being seen is the coupling of the right ventricle and pulmonary artery. Can this be used to diagnose the defect in pulmonary circulation? Put simply, right ventricle pulmonary artery coupling is linking of the right ventricular contractility to the right ventricular afterload, and to maintain an adequate cardiac output at the lowest possible energy cost. However, if the right ventricular contractility is not matching the pulmonary afterload, it is said to be uncoupled. The gold standard ratio is to measure the ventricular end systolic and arterial elastance, but it is considered to be normal if it is 1 to 2. In chronic pulmonary hypertension, if the ratio is less than 0.8, it is associated with right ventricular dysfunction. However, measuring this at the bedside is very, very problematic. It requires invasive and impractical measurements of the pressure volume loops, and pragmatic surrogates have been explored. These are the echo parameters like the right ventricular functional area change by PASP, the pulmonary artery systolic pressure, tricuspid annular plane systolic excursion, that is TAPSE, divided by PASP, and the tricuspid annular systolic velocity, that TASV, divided by PSP ratios. These ratios have been used to correlate the right ventricle and pulmonary artery coupling. But these values need evaluation. More studies are required, especially in critically ill patients, before they can be validated and we can change treatment at bedside. So the take-home message is, the cardiac output within the pulmonary circulation is generated by the right heart, and it is equal to the cardiac output of the systemic circulation. So whatever is coming out from the left ventricle has to be equal to the right ventricle. Chronic left heart failure is the most frequent cause of pulmonary hypertension in the ICU settings. Now, pulmonary hypertension of any class leads to right ventricular failure in the final stages. However, there are various phenotypes, and we still are not sure how to differentiate these phenotypes at the bedside in critically ill patients, and how to change the management in different phenotype so that we can improve the outcomes in patients who are developing pulmonary artery hypertensions in critical scenarios. So apart from these, our ventilation is also an important factor in increasing the pulmonary artery, especially in ARDS patients where we are using high PEEPs. This can result in an increased pulmonary artery hypertension, and we have to find ways how we can see our PEEP can be titrated to get the best pulmonary artery values. Thank you for your patience, and check our website for further information.